Now I'll invite Dr. Jaspreet Sukhija. He's going to talk on optimizing results in pediatric cataract surgery.
Can we have this? Very good morning to all of you, and thank you, Dr. Bhalla, for having me a part of this session. We've heard some great talks by prolific surgeons, achieving 20/20 within a couple of days. But in children, this is not really possible. You do target a 20/20, but maybe it takes years. It all depends when the child presents, what is the laterality of the cataract, and how the surgery has been done. So a lot of issues come into play. It's not just you have the best of formulas and you can get an accurate results. You aim for some target refraction, but then you have surprises in children. So I'll be discussing some of these issues in this presentation. My meaning of pediatric cataract surgery is like infants and toddlers. Children who are above 5 to 6 years usually have a more or less stable axial length and behaves like adults. So I would be stressing more upon the infants and toddlers. So in children, if you have a bilateral cataract, your management is different. If you have a unilateral cataract, it's all the more difficult to achieve that 20/20 vision because they would have strabismus and they would have deprivational amblyopia. So in children, you have to deal with what's the cause. Is it familial? Do you have some kind of a syndrome which is affecting it? Or is it kind of just an idiopathic cataract? So all these things in examination is a must. A consultation with the pediatrician is must to get the optimal outcome. So what are the areas of concern in a child with cataract? You have a small palpebral aperture as compared to an adult. So if you have a 3 or 4 month old child, it's very difficult to get into that small space. The eye is soft. The anterior chamber is shallow. Obviously, difficult manipulating those big instruments into the anterior chamber. The pupillary dilatation is the biggest problem here because the receptors for epinephrine are poorly developed and the uptake is very low. The dilator muscle is not that well developed. So your pupil does constrict and you have to have a good pupil size for a better surgery. What is the optimal age? Whether would you like to operate in a neonate or would you like to wait for a month? The risk of GA, inflammation, glaucoma, amblyopia, everything is there. Would you like to implant an IOL or leave the child a phakic? What is your target refraction? Emetropia, myopia, hyperopia? Where do you want to put the IOL? Because you're going to have visual exopacification if you don't do it properly. So all these things are very important. And of course, whether you want to do both eyes or whether you want to do single eye, because again, the GA risk is there. And of course, whether you want to implant a unifocal or an enhanced monofocal or a multifocal. So there are a lot of things in a child if you have to achieve a good visual outcome. So I'll just take you a brief overview of all these things. So the best visual outcome is during the first 6 weeks in unilateral cataract. And for bilateral, it is 8 to 10 weeks. It's more related to patching and compliance. As I said, amblyopia is a big issue in these cases. If you do very early surgery, it's been related to that there's a high incidence of glaucoma and inflammation, and of course, more risk with general anesthesia as well if it's very early. So the consensus is all non-essential surgery to be done after 4 weeks. IOL or aphakia in infants. Well, there are proponents and opponents of this issue. If they are children less than 6 months, probably just leave the child aphakic. But above 6 months, the consensus is more in favor of an IOL. So this is one of our studies which we did, a prospective study in infants versus a very popular study, the infant aphakia treatment study, and we found that our results of resurgery were much less as compared to the Western literature. IOL power calculation, as has been highlighted in adults, there's so many formulas, but what happens in children? In children, really, they're not fixing. You have to do your axial lengths when under general anesthesia, so you're bound to have surprises. But if you want to implant an IOL, one basic rule is have an axial length of more than 17 millimeters. Your corneal diameter should be 10 millimeters or more. And now as the acceptable age is becoming progressively younger, what is the optimal approach for determining IOL power in these children? So the refractive goal is myopic shift is going to occur because your axial length is increasing, you're going to have myopia. At what age would you like to, and what target refraction you want to achieve, like for a 1-year-old versus a 3-year-old is all different. These are debatable issues. Usually what we do is, depending upon the axial length and the keratometry, one chooses what IOL power can be implanted. So at birth, you can see how steep the cornea is, and most of the axial length elongation would occur in the first 2 years. So the average myopic shift is about 6 to 7 diopters, and that is what you aim for in the survey. If you see it's 4 to 6 diopters till 6 months and less than 4 at 1 year, and thereafter mild hyperopia. Of course, We used to use SRK, but now it's SRK2. The Barrett Universals 2 is still needs more research in children. So coming to the surgical strategy, you have a lot of things going on. You have a low scleral rigidity here. You have a small eye. You have a poor pupillary dilatation. You have an much more anterior elastic capsule. High risk of inflammation, high incidence of PCO leading to amblyopia. So all these things, one has to very accurately plan your surgical steps. So I'll just be taking you through some of these things. The first one is you need a well-dilated pupil. In children, meiosis is a big issue. So you can see we had used drops in this child, but did not dilate. Now what you're putting, you just put the intracameral dilator, and the pupil has dilated. And it would be there till the end of the surgery. So this is the most important step when you're starting a surgery, because everything is going to depend upon the pupillary dilatation. So these intracameral dilators are really helping us. Again, the second case, you put tip and blue dye, the pupil constricts. What you have to do is intracameral dilators. So that's how the pupil dilates. So this is something what we published, and you can see how well the pupil is dilated, and it maintains the stability till the end of the surgery. Next come your curvilinear capsular axis. You have to have a centripetal force in all these conditions. So you always stain your capsule because it makes it less elastic, and then gradually with the centripetal force have a 5.5 millimeters type of a anterior axis. So you can see here, this is some things we encounter here. You do it with a Utrata capsule. Now you use a vitrector axis because of the fibrosis you can see on the anterior capsule. So it's not coming up with the rhexis forceps, and what we're using is a vitrector. So always stain, and you can use different ways of doing your capsular axis. Lens matter aspiration, very important. Do not allow fluctuations in the anterior chamber. The more the anterior chamber fluctuates, the more inflammation. So you can see I'm not changing my ports. It's all done with the same port. The irrigation aspiration from one side, it's not coming out, you're not changing hands. So the lens matter is all being aspirated just with in one go. So that will not allow fluctuations of the anterior chamber. So it's a non-edited fast video, and we'll be just seeing that it'll be all finished within without changing your ports. So that's it. So why capsulotomy and when? Of course, all children less than 6 years, maybe 8 to 10 years, depending upon the cooperation of the child, depending upon the status of the posterior capsule. So there's a high rate of PCO, so you would have to do a posterior capsulotomy and anterior vitrectomy in these cases. There are different techniques. You could do a posterior rhexis, manual posterior rhexis, a vitrector-assisted capsulotomy, and some people do a radio frequency. So here what happens is when you're doing this capsulotomy, you always stain the vitreous with the triamcinolone, because it's a limited anterior vitrectomy what you want to do. So it just give you an idea about the completeness of your vitrectomy. So you could do a posterior rhexis using a Utrata forceps here. So sorry, I'll just go there. Yeah. So we're using Utrata forceps, and that's how the posterior rhexis was done. Or you could do it after IOL implantation as well. Stop this. So you can see that the capsule is really friable here. So if I do it manually, during my first attempt, it might go larger, and you might not be able to put an IOL. So it's safer to put the IOL and use a vitrector through the limbus. But you can also do it through the pars plana. If you find that the size of if the bag is tight, the IOL is little larger size, probably then going through the anterior route, you might tear the anterior capsule because you have to go behind. So you can see here, I'm going through the pars plana and doing the posterior rhexis. So these are different ways of having less inflammation and achieving good results. And the other thing is probably the last thing what I would like to mention here is not in the bag, but you can put your IOL behind. That's the posterior optic capture. So what we are doing is you have this IOL in the bag. So I put the IOL in the bag. The optic is going to go behind the posterior capsule, and the haptic is going to be in the bag. So what this does is it makes the anterior and posterior capsule fuse together. So when they are fused, you can see in the picture on the right, what happens, the visual axis is clear, a sombering ring is formation, and all the epithelial cells are sequestered in the bag because the bag is sealed.
Jaspreet, can you summarize?
Yes, sir. Yeah. So take home points, biometry, A-scan with handheld keratometer IOL master, use SRK2 or Barrett. Refractive goals, 4 to 5 diopters, less in unilateral cataracts. The optimal time is 6 to 8 weeks. Use intracameral dilators for addition. And all children less than 6 years should have an anterior vitrectomy with a PPC. And primary IOL implantation in those above 6 months. And occlusion is the key for better outcomes in unilateral cataracts. Thank you for your attention. I just want to finish up with this video. A good aphakia is much better than a bad pseudoaphakia. So this is an aphakic, less than 6-month-old child. He's looking for his glasses. And you can see here how happy he is wearing his glasses. So this is a good aphakia which has been done, and probably over the years, he might have good vision. I cannot predict how much he will have. Thank you so much.
Thank you.